Today we're going to talk about Alzheimer's disease. Joining us is Dr. Jennifer Pauldurai, a cognitive behavioral neurologist at Inova who specializes in memory disorders and dementia.
Thank you so much for having me. So as you said, I'm a cognitive thinking doctor and behavior doctor. So neurologists are specialists in the brain, of course, but there's this esoteric, almost abstract way of thinking of the brain as a thinking, leading organ. Like, for example, the knee helps us to walk. Our mouth helps us to digest food and chew food, but the brain helps us do all of that. The brain's actually in charge of the mouth, in charge of the knee, in charge of our feet, right? So as the CEO or the boss of this body, this organism, the brain, when it dysfunctions, can have changes in thinking, in memory, in walking, in talking, in chewing, in feeling. So the brain is this all-encompassing organ, and I find it kind of significant to be able to help someone with a brain dysfunction because it's not just like a broken leg. When you've got changes in the brain, you can have a change in your life and who you are as a person and in your family. So that's kind of what I do all day, every day.
So tell us what Alzheimer's is. How does that differ from other types of dementia?
Yeah, that's a very good question. Whatever a healthy brain is supposed to do is to lead this body, to be able to take our pills, to eat, to manage our human life on this planet independently. That means even if we're like 150 years old, our brain should be able to help us as animals live alone. So if we can't do that because of a cognitive dysfunction, like if I need somebody to help me with my pills, if I need someone to help me with my bills, if I need someone to make meals for me because cognitively I won't be able to do that, that's a generic broad term called dementia. Mm-hmm. So dementia just means my brain needs a buddy, needs assistance to do day-to-day survival human things. Within that general umbrella term, though, different causes of dementia exist, okay? Just like headache can be caused by migraine or stroke or head injury, dementia can be caused by Alzheimer's, Lewy body, Parkinson's, frontotemporal. There's a slew of other causes of dementia. Alzheimer's is arguably the most common one as we get older, though. That's why everybody hears about it or talks about it. But Alzheimer's is not like the worst, severest form of dementia. I get that question a lot. That's not true. It's just dementia is a description. Alzheimer's is one specific cause.
And why do you think, if I put 100 people in a room and said the word dementia, Alzheimer's would be the number one name or word that would probably be recognized by the layperson. Why is that? Why is that the most recognized dementia?
It's the most common. It's when you hear about it in the news and in movies even, or even in books, it's like that, kind of elderly person who repeats their stories but is very pleasant and gets confused. Like that's the typical picture of Alzheimer's, and that idea is perpetuated over and over again, I think. But there are other symptoms of dementia. Like, for example, some dementias cause movement change, like falling down. That's not that typical of Alzheimer's. So people just don't know what they don't know, I think. So what we do hear about in the news or TV, we're like, okay, Alzheimer's. There also weren't a whole lot of biomarkers and ways to diagnose these different diseases, too. So everybody was just kind of calling everything Alzheimer's before. Nobody really figured out the distinction, although now I would argue there's great value in figuring out what's what, because now we have disease-modifying therapies. We have treatments for Alzheimer's. We have different medicines that I give for Alzheimer's, but not for Lewy body, for example. So maybe 10 years ago, it wouldn't have made a difference if we had it right or wrong, but now it makes a difference.
What is Lewy body?
Lewy body is another type of dementia, the second most common one that I diagnose. It's caused by a buildup of synuclein, which is the same kind of plaque that builds up in Parkinson's disease. Lewy body, this kind of dementia, though, it changes like our attention and alertness levels, so they're not necessarily forgetful as much as inattentive. They're like falling asleep on you all day. And because we're inattentive, our brain can actually fill in the blank spots with like hallucinations. We might think there's a dog or a cat or somebody in the yard. So it has a little bit more delusional aspect to it. Delusions and hallucinations can happen with any type of dementia, but Lewy body is more particular for that, particularly early on.
So how do you tell the difference between someone who has a type of dementia versus somebody that's just having natural forgetfulness, either because they're overtired or they're in perimenopause or whatever the reason might be?
As we age, we all get a little bit slower. It might take a little bit longer for us to find that name or that word. That's probably
a little bit of word searching.
Yeah, that like just what was that tip of the tongue syndrome is what I call it. It's not a real thing.
And actually, what is the explanation for that?
Yeah, it means I know the word. It's like, for example, I had somebody trouble with the word kangaroo. I know it. It's that jumping thing. It's the one in Australia. It's really strong. but I couldn't find the word kangaroo.
And why does that happen? Is like in the absence of dementia diagnosis.
Yeah.
There is that, okay, I'm getting
Yes.
older, I'm getting more forgetful.
We've all
It's a
had those
phrase.
moments.
Yeah.
Everyone says that.
Yes.
Other than us saying it, is there a clear biological explanation for that?
There's a couple of different things that could be going on. So aphasia means I am having trouble with language. I actually cannot find that word because the language center in my brain is broken. The language center just so happens to be near the memory centers where a lot of these dementias tend to happen. Alternatively, and more commonly, I would advocate, we have that trouble finding the word because our brain is less efficient. So when we are stressed, when we are tired, when we are low on our vitamins, when we have so many other things in our mind, our brain doesn't have room to focus and pay attention to things like kangaroo or whatever word we're searching for. So there's hardware problems like brain cells dying, tumor in head, stroke, too much blood. Whatever it is, those are structural hardware changes in the brain that can cause dysfunction. But more common is software dysfunction, as in the wires are not connecting well because I am too tired. I'm not treating my brain well. I'm not eating my fruits and vegetables. I've been eating French fries all day, every day. Those are all going to cloud our thinking, and it can cause that, like, what's that word, inefficiency. It's kind of like not giving the brain the right fuel we need.
Okay. That's really helpful. And then, so getting back to how can you tell the difference when you're seeing a patient that it's normal forgetfulness versus something more serious?
So some of the red flags I always screen for are you actually having dysfunction in your day-to-day affairs? Remember, dementia means I cannot live on my own. So if you are kind of younger and having tiredness, fatigue, menopause, all those things that you talked about earlier, you should still be able to pay your bills, kind of make it to your appointments. You should still be able to do your survival things well. So if there is
You're
a
still
decline,
managing your life.
yeah, even if it's sloppy, we're managing our life. And that's usually a red flag when we're having declines in function. When you can't manage those day-to-day functions and somebody else is bringing you into the appointment, that's always a red flag to me. That means it's not just you, somebody else is noticing it. But we do have ways to check. For example, the forgetfulness, the kind of slower thinking that we experience in menopause or with stress is very different from the kind of memory changes that happen with Alzheimer's disease. We have ways to categorize the pattern of cognitive change using neuropsychological testing, cognitive testing, memory testing, where we sit you down and have you remember this, draw this, figure out this pattern. Often it can take hours, but it's not a pass-fail kind of experience. It's rather for me to understand what domains of cognition are broken. We're troubleshooting the brain essentially, because I know that Alzheimer's looks different than Lewy, then looks different than frontal, then looks different from menopause. And so first and foremost, I need that test of sorts, a cognitive test to tell me what's wrong. And then we also do other things like MRI scans, blood tests. Like if I do a blood test and I can tell that your kidney's off, well, maybe we got to fix that before we start exploring this Alzheimer's business. So there's certainly different risk factors throughout life that can increase our forgetfulness and our ability to focus. And not always is it dementia, but we do have to take that seriously the older we get, because the older we get, the more we are at risk for dementias.
Yes, that makes sense. When you see a patient that has dementia, what's the care plan look like?
By definition, it is a neurodegenerative disease. It gets worse over time, and there are no dementias that have a cure per se. That means they get worse over time. But that doesn't mean we don't have treatments. So for every single symptom, we have something to make your life a little bit better. It's kind of like having arthritis in your brain. A lot of us have arthritis in our back or our knees, right? And we don't really cure arthritis, but we have rehab and we have ways to support our knee and our neck, right? Similarly, the brain dementias do not have a cure per se, but we connect people with the resources and the team they need to be able to live life the way they fully want to. There's a lot of change in autonomy, in agency. There's a lot of changes in relationships and caregiving, and kind of building the foundation of, okay, who is going to help me through this chronic illness is very foundational in all of our treatment plans. There are medications that can help. For example, Alzheimer's disease has disease-modifying therapies now on the market. These just got approved in the last couple of years. Lewy body, I've got medications for that. Frontotemporal, if you're having trouble sleeping, we've got sleeping things. If you're having trouble eating, we have medications to help you, maintain hunger. So we do have ways to help the symptoms of your disease, even if we don't have a way to slow down or reverse the disease. So care plan, how do I treat this? First and foremost is defining what it is, because not all dementias are treated the same, right? And after I figure out diagnostically what's going on, the second part of treatment is just really helping the family and the patient understand what changes to expect. Is this normal? Is this not normal? Is this something worth exploring? Or, is this something that I'm not worried about? And then from there, as symptoms pop up, we target those symptoms.
I'm sure many patients ask you this question, but if you receive a diagnosis like that, I'm sure they want to know, like, how long am I going to maintain sort of where I am presently? Like, I'm obviously coming to see you because I'm noticing some sort of deficit, however long that's been building up and whatever threshold sort of led them to come seek help. How do you answer that question? Because I'm sure it's a little bit unique for every patient.
Right. And unique to every disease, right? For example, Alzheimer's disease typically runs its course over 10 to 15 years. Lewy body is closer to 7 to 10 years. Frontotemporal is, again, closer to 7 to 10 years. Then there's other types of dementias, like some people have dementia after having a traumatic brain injury, and that is just something they live with forever. That's just how it is. It doesn't really get better. It doesn't really get worse. It's just kind of there.
Their new way of life.
That's just their way of life. So really, I can't answer that question without knowing what their specific diagnosis is. It's kind of like when you go see a doctor for headache, you're not just going to be like, well, what is my prognosis? We have to figure out what the headache is from, and then we'll be able to better answer that question.
And how much are you were talking about, obviously, treatments for Alzheimer's mainly revolving around or focusing on the symptoms or the circumstances that arise because of Alzheimer's, right? And to use your arthritis analogy, if we're talking about an inflammatory arthritis, a lot of the treatments are calming the inflammation, et cetera. But a lot of the progress in inflammatory arthritis treatment over the years has been actually disease-modifying drugs, right? And trying to at least slow the progression of the disease. How much of an area of research focuses that right now with Alzheimer's? And are there actually any drugs in the pipeline that are more in that direction, right? Not the hunger drug or the
sleep drug or
we're actually targeting some of the root of the problem.
Love this question. Alzheimer's disease is caused by a plaque, amyloid plaque that builds up in the brain. We now have amyloid targeting monoclonal antibodies. So we do have 2 drugs on the market, Leqembi and Kisunla, also known as lecanemab and donanemab. These 2 medications were approved in the last couple of years, and Alzheimer's is the only type of dementia that actually has disease-modifying therapies. That means we have ways to get rid of the amyloid from the brain at risk, and it's really only targeting towards people who don't have a lot of amyloid burden. That means I got to catch you early on in the disease. After somebody has moderate, severe, advanced dementias, that means the burden of the disease, the amyloid is eating away at the brain so much that it would probably be more risk than benefit to treat. But if I catch you very early on, that person who's just having mild symptoms and you're like, wait, what is it? If we figure out that it's early stages of Alzheimer's, now we have a way to kind of clean up this amyloid from the brain and stave off that progression into dementia. It's very exciting.
Can it reverse? Can you clean out the plaque and get you back to kind of like optimal brain health?
Not optimal brain health, because the reason the plaque is there is because of a misfolded protein. So that DNA thing that's causing the protein to actually misfold is still a problem. We will probably at some point in the future come out with some kind of gene therapy to reverse that DNA mistake. But in the meantime, imagine DNA mistake, amyloid itty bitty particles, bigger particles, amyloid plaque that causes the brain cells to die. Now at least we can target those plaques and amyloid precursors to clean it out so no more damage is being done to the brain. It has been very successful at cleaning out amyloid, by the way. Like I'm getting some PET scans back with no amyloid.
Like make that real in terms of the patient experience.
So that usually means stability. So if you imagine Alzheimer's kind of like a cliff of everybody gets worse over time, this slows down the decline by about 30%. So instead of going at it at 100 miles an hour, we're going at it at 70 miles an hour. So not a reversal, not a cure, but I think we're headed in the right direction. I also think if I can slow it down by that 30%, right, then something else will come out. Maybe an additional kind of agent over the next few years that could maybe cure it, maybe get you even better, right? So that I'm really hopeful about these things.
How do you approach prevention?
Yeah, I look at somebody's risk factors. Like, for example, if you're a boxer, martial artist, something like that, where you've gotten hit on the head many, many times, that is going to increase the inflammatory response, the cytokines. Your brain is going to be a little bit more on edge, even apart from the structural damage that you may have suffered. People with head injuries are more likely to get dementias. People that had diabetes, metabolic dysfunction, hypertension that is uncontrolled in middle life, that means middle life, not even older, you are more likely to get dementia. This is a systemic illness. People that smoke and drink more than they should are more likely to get dementias. People with untreated mental health disorders, anxieties, depressions, PTSD, more likely to get dementia. So when we delve into this world of, well, let's start treatment early before you have symptoms, it's not just about the amyloid. If you're going to have amyloid and take this drug, but then keep smoking, it's actually not going to do that much for you. So we have to be very intentional about the health of our brain and what we are feeding our brain. That means, are we doing our best to stay engaged? Are we doing our best to not have exposures to stressors, to toxins, to head injuries? Are we wearing seatbelts? Are we wearing helmets? Those kind of things to protect our children, because it starts from day one and maybe even before day one. There's a lot of research shows that when we are still in the womb, we have exposure to maternal stressors. If mom had, not enough access to food or was in a household of violence or abuse, that stress response from mom crosses the placenta and makes the baby more at risk for diseases later in life. So obviously, there are some things we can't control, right? Like I can't control what kind of stress my mom had, but I can control if I am going to go to bed on time and get my 8 hours of sleep. Because if I don't let my brain get rest now, then it builds up over time to, at 80 years old, I'm going to be like, wait, why did this happen to me? It's a lifetime of stressors. So that's what prevention is all about. Thinking about your brain just like we would think about our heart and how we take care of our heart. Similar thing, am I staying active and using my brain and protecting my brain before you reach, later stages in life?
How would you decide who are going to be your best candidates for the pre-point A, protection?
And it really depends, because it has to be Alzheimer's. I think the greatest research right now is Alzheimer's, right? And remember, we talked about how there's several other types of dementia. So I would have to define that there's amyloid. How we define that there's amyloid, that plaque, we have blood tests now that just got approved in the last 6 months, by the way. We have PET scans that light up amyloid in the brain, and we have spinal fluid. So when you do a lumbar puncture or a spinal tap, you can remove it and measure the amyloid there. So that one of those three has to be done. If that's not there, then you have brain health risks because of something else. Maybe Lewy, maybe you have TBI, maybe you have concussion, some other cause of cognitive decline. Because you can have cognitive impairment because you have ADHD that's undiagnosed, right? And I'm not going to give you a strong Alzheimer's medicine when it's all ADHD. So it goes back to step one, get it sorted. Not all memory loss is the same. What is the cause of my cognitive change? Is it untreated and undiagnosed ADHD? Is it just menopause and sleep deprivation? Or is this the early signs or early risk factors for Alzheimer's? And that's defined by that presence of amyloid.
And how much before symptoms show up would you expect to see these things light up on these tests you're talking about?
Yeah, amyloid can be positive like 10 years before symptoms show up. So it's not a hard defined line, of course, but I would go based off of what the risk factors are. So if I meet you and you're the healthiest person I've ever met, no family history of Alzheimer's, no family history of dementia, you're taking really good care of yourself, not on any medications, my first instinct is not to go looking for amyloid. Likely you are going to do all the preventative things that I would want you to do, that I'm not going to go out of my way to, look for trouble. But if you have 4 or 5 generations of Alzheimer's in your family, we already work a stressful job, and I know that you're not getting as much sleep. I know that this is a brain, this is a human that is more susceptible to Alzheimer's, and I would take that a little bit more seriously.
So what else can somebody that's in that middle age kind of category be doing to protect their brain health later? You talked about sleep, you talked about fruits and vegetables. Are there supplements? Are there things, vitamins that we should be thinking about? Or what do you suggest kind of help somebody give themselves the best chance at longevity when it comes to brain health?
Use your brain the way it was made to be used. I think in this middle age, when people are retiring, when people are changing careers, this is when we lose a little bit of our brain exercise. We get into routines and we don't try new things. When we're young, remember, we're trying daycare and let's just put them in soccer practice and art practice and let's just see what happens. Remember that excitement and that cognitive exercise we got from that? We don't do that so much as we get older, and that's actually very, very important. So one of the best things you can do to protect your brain, go do something fun, something new, something challenging. Don't stay stuck in your routine, whether that means a new hobby or a new travel experience or making a new friend. That social, cognitive, and physical engagement is exercise for the brain.
That's great news and fun.
But to answer more specifically about supplements, in general, if you are deficient in vitamin D, supplement vitamin D. If you are deficient in vitamin B12, B as in boy, that's another one you should take a supplement for. I don't like the idea of adding supplements when you might already have enough in your diet and kind of your intake. So I'm not one to support, kind of those multivitamins, brain stronger, neuro focus kind of medications. I think they're based on good science. I think most of the time they don't hurt, but they are usually additive and they don't necessarily actually provide anything that you couldn't get from doing a good job with your health. So
It's vitamin D and B12. Those.
Yeah, I would focus on B12, D. Magnesium is a very good brain health chemical. So if you have some kind of magnesium in your diet or in your cabinet, that would be good. And I like omega-3 fish oils. Those are the 4 I only really ever recommend. Everything else.
Creatine. That's one I hear a lot of associated with brain health.
That helps.
Have you heard that too, I assume?
Yes. So there's a lot of research going into like creatine and, SAM and cholines. And there's so many things we can talk about. But most of the time people are not deficient in those things, and taking them is kind of like an easy way to say I'm doing something, but it doesn't lead to cognitive change. That I would say do what helps keep your brain protected. You don't need to go above the norm on the creatine and some of these other supplements. There's not enough research behind it to say you have to take it.
That's really good advice. I know we're getting close on time, but I'd be remiss if I didn't ask you to talk about the role of the caregiver. This is a disease that can be very daunting and taxing for a caregiver, especially as it progresses. What advice would you give somebody caring for somebody that has Alzheimer's or something else? Yeah,
very good question. Be gracious to yourself. You're going to mess up. Nobody has a rule book or a manual for how to take care of somebody with Alzheimer's or another dementia. Not even doctors. We don't even know the best thing to say. Not a therapist. Nobody has a rule book. Humans are very complicated, and we get even more complicated when we have dementia. That being said, caregivers often need a care partner themselves. Don't try to do it all on your own. This is a giant journey ahead of us. It's a chronic illness. It's going to change your life. It's going to change their life. So create a team, a village, a community of who's going to help you, and make sure that you have the opportunity to get away and take care of yourself. I know we get into these roles of, well, I'm a wife, I'm a husband, I'm his person, I'm his mother. I have to, but that's not that doesn't mean you have to sacrifice your own time and health to make that happen. That this is not a foreign idea to us. Dementia is something that we have known about for hundreds of years. We have care managers, we have therapists, we have patient care coordinators, we have nonprofit organizations, we have research. Believe me when I say you are not in this alone. Reach out to the people who can help you, because we are here waiting to help you. And honestly, we want to help you because it's more about the care partner at some point in the disease than it is even about the person with the cognitive impairment.
I imagine at first the person knows and understands they have it, but over time they don't even realize
exactly.
it. So the full weight of this is on the caregiver.
Yeah. Like a lot of people will be like, isn't it so sad to like go through the stages of dementia? And I say, well, usually the person doesn't realize they have dementia after about mild or moderate stages. The people who have it the most or feel it are the care partners. So it's the care partners that need the support groups, that need the community, that need the support and buffering. And luckily they're out there. We are so lucky to live in this area where we have so many dementia resources. We just have to get you connected. When we first get a diagnosis like dementia, it can feel very daunting. But one of the best parts of my job is to see somebody at a 6-month follow-up. And when I first met them and gave them a diagnosis, it was life-changing and upside down. And what are we going to do? And I have to quit my job. And what about insurance and this and that? But then in 6 months, they have that confidence of, I have a plan. I got a financial advisor. We know what we want to do. And if he needs more help, we got a nurse set up. And if he needs this and if she needs this, having a plan gives you power. And that's what I'm hoping to do with this early detection, early diagnosis stuff is take power back into your hands, because a lot of medical illness takes away agency.
That's a great note to end on. Thank you so much for being with us. This was enlightening and so helpful. And I think something that people that deal with this disease, whether, they're facing this or dealing, they're a caregiver, this is a very weighty issue. And so it's great to have you help us shed some light on it.
Thank you so much for having me.